The stories are just so compelling. This lady was a classical pianist for almost 50 years.
Wow.
And she could not move her left thumb. And ultimately, the surgeon basically said, I think it's time to operate on this. Your pain might go away, but you'll probably have decreased mobility. So once we embolized her hand, she came back at 1 month. I remember her pain scale was 8 to 9 over 10 before the procedure. It had come down to 5, and she said, yeah, the pain's better, but I still can't play the piano effortlessly. Came back at 3 months, painless.
Wow. Hey guys, it is Justin here with the OBL Marketing Blueprint, and I'm on with Dr. Sid Rao and Amr out of
Vascular Solutions of North Carolina.
No,
Thank you.
Rao Clinic. Just say Rao Clinic. That'd be good.
And I'm super excited to have you guys on because something that I don't know about, I'm trying to learn more, is the whole area of hand embolization. But before we get into all that and some of the things that are coming up for you guys, can you guys give me a quick background of how did you go from being like a limb preservation PAD to now you're doing all these new treatments for chronic pain?
Yeah. Amir, you want to take this one?
Yeah. So when I came here a year and a half ago, Dr. Rao was like telling me about he was doing GAE and he was telling me about the results. And I was like, oh man, this is kind of like unheard of. And I started talking to the patients, and the patients were echoing the exact same thing. And then we just all I started getting interested in it, and we started talking to patients every time they had a procedure done, and they were doing testimonials. And once that started happening, I just think Dr. Rao started evolving, and he was like, well, there's other areas that also can be treated. And since he had perfected the sort of the knee piece of it, it was trial and learning and stuff. But once he had perfected that, he started doing it on other joints, and we started getting very similar results. And this is obviously one of those procedures where it's very organic. It markets itself. Once people see their friends, family members, like, oh wow, this, you're walking better, your thumb is better, you don't have plantar fasciitis, your foot is doing much better. It just automatically takes off, and people just start calling. I always share this story, but our referral coordinator told us one day that we had 4 patients call back to back, new patients, same street name, but different addresses, just one number apart.
Just neighbors?
So one of the neighbors just got a procedure done, and the neighbors saw it, and all 4 of them just happened to call back to back. So I think they all ran inside and just directly made a phone call to us. So I think it's just organic. Once you start doing something, it works, and it just kind of took off.
So that kind of.
I've always found this. I've always found this question very interesting, Justin, because a lot of people ask me, "Hey, you're an interventional cardiologist by training. How'd you get into this field?" And I'm double boarded. I had an extra year of fellowship training in endovascular medicine, and that's how I got into treating PAD. But from a clinical perspective, we can treat somebody's claudication, we can improve the blood flow and heal a wound. But if they don't walk, they are still at very high risk of dying from cardiovascular disease and cancer. And that's why I often kind of allude to it as the moral imperative. I think every endovascular physician that takes care of lower extremity peripheral arterial disease should have some knowledge of this field, because I think it is a very patient-centric approach. It complements what you're doing for their circulation by going one step ahead and reducing their knee pain, so that you can realize that ultimate goal of keeping patients walking,
No, and it's awesome because you guys see it. I have the data, the amount of PAD patients that are a GAE candidate and the amount of GAE candidates that are PAD patients. If you're not doing both and willing to treat that, you're doing a disservice.
Correct.
Talk to me on the hand embolization. You guys just had this paper come out that you guys have co-authored. what brought the what made you guys want to do the paper in general, and like what kind of has come from those findings?
So yeah, so we have an active research program here that's very outcomes based, and the way that we kind of started or decided to do the paper on hand embolization is my mom had, once I learned about this procedure, my mom actually had her knee done by Dr. Rao. When she had her knee done, my mom for 15 years could barely walk without her cane or a walker. She had her knee done and 2 days later walked 4,805 steps. We know that because she measured it on her Fitbit. So no cane, no walker. And for me, that was like, that hit home, right? That was unbelievable. So now we move to the hand. My dad was an engineer his entire career. My sisters and I love it because when you come to our house, he'd fix all of our stuff around the house. But for about the last, like I'd say 7 years or so, he couldn't do anything because he couldn't move his thumb. His thumb was hurting. He couldn't hold tools anymore. So I could see how it limited him. So I talked to Dr. Rao. Dr. Rao did the procedure on my dad's hand or thumb, and almost immediately he had full range of motion. He was like, it doesn't hurt anymore. And so once I saw that, like I was a believer. My family's a walking billboard for this. I firsthand, when you see it firsthand, you can't deny the results.
No pun intended, right?
Absolutely, exactly. No pun intended. So Dr. Rao was like, "Hey, we should start recording the results and do a paper on it." And that's kind of how it had started. And then since then, we've done quite a few of the hand ones.
So Justin, the way this really took off was again quite organic. It was really a need of the hour. So we had done enough GAEs by then, and one of my referring physicians said, "Hey, I have this lady that I want you to see because I think you can probably help her for this hand osteoarthritis." And this was a couple of years ago, and I had never done any. But the story was so compelling, Justin. And that's the beauty of all these embolization patients, right? The stories are just so compelling. This lady was a classical pianist for almost 50 years.
Wow.
That was the thing she woke up for every day morning, to play the piano, to teach the piano. And she could not move her left thumb. She had seen a couple of hand specialists and had been given multiple injections, occupational therapy. She wore braces. And ultimately, the surgeon basically said, I think it's time to operate on this. Your pain might go away, but you'll probably have decreased mobility. And for a lady who still loved what she did every morning when she woke up, this was a terrible, terrible thing for her to hear. So she came to me almost in tears saying, "Hey, my hand surgeon says that there's a good chance that I might be pain-free, but I may not ever play the piano again." So I told her that the field itself a couple of years ago was in its infancy, and I said, "I'm happy to try this." I said, "The downside I think is very minimal. I've done hundreds of knees now very safely, and I'll be extra careful, and I'm happy to do this." So once we embolized her hand, she came back at 1 month. I remember her pain scale was 8 to 9/10 before the procedure. It had come down to 5, and she said, "Yeah, the pain's better, but I still can't play the piano effortlessly." Came back at 3 months, painless.
Wow.
She is still teaching piano 14 months after I have embolized her hand, I think 14 or 15 months, Justin. So just imagine the quality of life improvement. I mean, she sees me in the hallway. She comes and hugs me now because we gave her back something she so dearly loved, which is to play the piano. So these are the kind of stories that you get with musculoskeletal embolization.
Well, and you said something, there was two things that stood out. One, like I've gotten to interview so many patients post-op, and it's almost always the same terrible story of pain started affecting their life, doctor to doctor, injection to injection, and they're at this precipice of doing a life-altering surgery. And then someone tells them, like, oh, you don't really need that. Like and their life is completely different. And it's cool to hear stories like that. My question to you I had as you were saying that is, I just lost my train of thought. And it was essentially on the hand embolization, like I think is it going to come down to awareness? Because people don't even think about, is there a procedure? Is there a treatment for something? I mean, a knee, we think about knees, we think about that. But even for me, I was kind of unaware of the hand arthritis issue or epidemic necessarily.
Yeah, this is an extraordinarily common site. The thumb or the first carpal metacarpal joint is an extraordinarily common site for osteoarthritis, almost as common as knees, and some in women actually more common than in knees. And you're right, it is an awareness issue. I think a lot of people just dismiss it off as saying, oh, well, I'm getting old or I have some mild arthritis. But when you look at the x-rays of these people that have kind of lived with this pain, I mean, that joint looks destroyed, you know? And why does it go from, oh, I have mild pain to a joint that's completely destroyed? It's what you said, awareness. People don't think this is a real illness.
Well, and I remembered what I thought I was going to say now is you talking to that woman, and this is where I love where embolization and IR is going. It's like there's really not a downside. If we do this and it doesn't work, you don't have anything, you're not any worse off. You have an embolization particle in your hand somewhere, big deal, versus all the other alternatives. And like I love the minimal risk, but the huge gain that comes with what you guys are doing.
Yeah, and to be factually correct, you know, I mean, no procedure is 100% safe. But like you said, when you look at the risk benefit ratio, it's extraordinarily in favor of doing the procedure most of the time.
Yeah, well, I mean, and just we can go to anyone's watching this knows, there's the infection, the sites, the surgeries, incisions. I mean, so many things that are just taken off the table when you guys do the embolizations. But that kind of comes to my next question. You guys have been pioneering all these things. So you have this new conference coming out, the Multidisciplinary Musculoskeletal Care Conference. Can you guys kind of give an overview of what's going to make this conference different than, say, some of the other ones that are out there?
Yeah, so I'm gonna pitch in if you don't mind, Amir. So um, this comes the preface to this answer is a disclaimer, Justin.
Okay.
And I think it's time that a lot of people got off their moral high ground and said this is a field in its nascency, right? It's nowhere perfect yet. I think the most patient-centric thing to do is to understand how best we can help the patient, not the best procedure that a proceduralist like me can do, right? Every conference that I have gone to, every speaker I have gone to wants to own these patients. And I think that's the wrong approach to take. I think the right approach is to be patient-centric and say, what does this patient need? Because I'll tell you, look at all the published results. I give a lot of kudos to the interventional radiologists. They have been very diligent in publishing their results, right? But the procedure doesn't work 100% of the time. It does fail, depending upon the patient, 20 to 35% of the time, it does fail. What do you do? What do you tell that mother, that sister, that father? What do you tell them? You have to be able to look them in the eye and say, hey, look, what I didn't work, but I have other specialists in my umbrella that will work. So that can help you. Other specialists in my umbrella that can help you. So it is with this singular patient-centric effort or patient-centric attitude that I said, we got to practice what we preach. So we actually have a Duke-trained orthopedic surgeon who works for us, and we have an interventional pain specialist. So what I do tell patients is, hey, while there is a chance of failure with this procedure, between the three of us, we'll help you out. We're not going to leave you hanging dry. So that was the main idea behind coming up with a multidisciplinary conference, because I think we can all learn from each other, Justin. I mean, you can tell me what the prevalence of the problem is and what stories you've heard. I mean, an orthopedic surgeon can tell me what they have done to correct a limb abnormality that's associated with advanced osteoarthritis and how it helps the patient walk better. The interventional pain specialist can tell me where my procedure didn't work and what they can do better, and search for other causes of knee pain. I can tell an orthopedic surgeon that has tried everything that he or she can and say, hey, man, look, your knee replacement didn't work. I can actually help this patient. So I think the right thing to do is for all specialties to come under one roof and say, how can we help this patient? And this is not without precedent. Look at peripheral arterial disease, right? No one specialist can treat a patient with advanced peripheral arterial disease. You need an endocrinologist, you need a primary care physician, you need a nephrologist, you need a vascular surgeon, you need an endovascular specialist. I mean, you need different flavors of specialties, different areas of knowledge coming together to serve only one purpose, which is to serve the patient, right?
Well, I don't know why the visual I had in my head when you were saying that is like, you have your tool bag, right? And if I have a Phillips screw and I only have a flathead screwdriver, I'm going to try to make that work. And sometimes it might, but it also might damage the screw. And I feel like when you're trying to take an orthopedic place where something else should be there and vice versa, it can work, but is it the best option?
Correct. Correct.
So real quick, just to set some precedents here, because I know everyone watching this is different. We have practice managers, we have vascular surgeons, we have interventional radiologists. In a nutshell, could you just explain the science behind how embolization works in like very simple terms for pain?
Yeah. So for the longest time, let's just take the knee, right? For the longest time, knee osteoarthritis has been thought to be this old, boring, degenerative illness. You get old, you have some trauma, and the knee starts degenerating, and ultimately it becomes bone on bone. And the treatments have only been fourfold over the last 40 years. You take pain medications, you can get some injections, you can get physical therapy, and when all else fails, you get your knee replaced. But there's been some incredible work out of England, out of France, out of Japan that has looked at this illness in greater detail and and what they have discovered is that for years and years before it becomes the so-called bone-on-bone disease, there's a tremendous amount of vascular inflammation going on, vascular mediated inflammation, a lot of abnormal blood vessels, abnormal blood vessels that you're not born with, but you acquire as part of the inflammatory process that just perpetuate the inflammatory process and then cause progressive joint destruction. So the research that we have so far suggests that if you kill off those abnormal blood vessels, then you can potentially stop the progression of the disease, at least provide some sort of pain relief for an intermediate period of time. And why am I saying intermediate period of time? Because we don't have 5 and 10-year follow-up, but the results look extraordinarily promising. So this is the first treatment that actually strikes at the root cause of the problem rather than treating a symptom. And that's why I think it has had such reliably reproducible results.
Well, and that's kind of my question. So going into GAE, how would you say, just as because I mean, you're multidisciplinary, what gap has GAE filled in that continuum? Because I think there was a place where someone had knee pain, they went through steps. Where do you feel GAE has come in now?
Oh, it's just filled this humongous lacuna, right? So if you think about it, a lot of people start having symptoms in their 40s and 50s, and they're too young to get a knee replacement. A lot of patients who are in the 70s and 80s who have a bunch of medical comorbidities, they cannot get knee replacement. So there's this huge swath of patients that are either too young, too healthy, too sick, or just too far out in the disease that they're not the perfect surgical candidates. They have tons of illnesses. So what do you do for those people that's different from what you've done for the last 40 years? And the answer is GAE. The answer is GAE. You can at least try this as a treatment for people who don't have a bunch of great other options, right? So, for instance, there's 33 million people living with knee osteoarthritis, very conservatively in the United States. And sure, I think GA is not the first line of therapy, but if pain medications, if physical therapy, if intraarticular steroids and other injections don't work, then why not try something minimally invasive before progressing to something that is much more invasive? And so with GAE being kind of inserted into the treatment paradigm, we've helped now hundreds and hundreds of patients. I mean, we're truly now an experience center. We've done over 1,000 knees now in the last few years, and our results are pretty much on track with what has been published so far. We have an IRB registry. We follow these patients, and the results are pretty much on track with what's been published so far. So it's really, I think there's been an unmet need for taking care of chronic knee pain, and GAE meets that need.
Well, and something you just said, and again, I get to see things from a little different lens of working with all the clinics and stuff, but the amount of patients in this population that won't take proactive care for their PAD, they won't take proactive care for a lot of serious conditions, but they'll come in for a knee pain consult. And I always think about this because the amount of times I've gotten a call from a doctor that's like, hey, here's a picture of my GAE patient's foot that was black. What would the orthopedist have done? And I'm not to poo-poo orthopedists, but they aren't equipped to necessarily see that. And so it's for anyone that's watching this that maybe is not in the MSK space, no, these people, they need your help, and they'll come in for an MSK pain point when there's so much more. Like, you are this person's caregiver for a year if you do it right.
Exactly. Agree with you. Yep.
So looking at the kind of the healthcare landscape in the next year or so, we're seeing all these challenges, declining Medicare reimbursements, moving towards like hospital consolidation. How does focusing on like innovative procedures like an embolization help someone get a strategic advantage for like an independent OBL or ASC?
I'll have my business guy answer that.
Well, as Dr. Rao mentioned, like there's 33 million people with knee osteoarthritis. The CDC data shows that there's 68 million people in the country with osteoarthritis in all of their joints, symptomatic. So there's enough of the disease prevalent that I don't know if there's enough physicians to take care of it all. And this, it's an outpatient procedure. It's relatively quick, it's 30, 45 minutes. And so I think that I don't think that it affects the private practices or OBLs at all in any way. There's so much prevalent disease that, yeah, I'm not concerned about it.
There are not enough hospitals in the United States to take care of the burden of osteoarthritic disease. There's just not enough hospitals in the US that can take care of the burden of this disease, Justin. Number one. Number two, there is no reason this procedure has to be an inpatient procedure. Absolutely none. We are formally affiliated with some of the bariatric surgery programs in our area. We have pioneered doing this procedure from minimally invasive tibiopedal access. I've done over 700 patients now from the foot. How can you justify doing a GAE from the groin in somebody with a BMI of 45 safely? How can you look them in the eye and say, I think this is going to be a safe procedure for you? No, you cannot. So, number one, there's a lot of patients. Number two, none of these need to go to the hospital. I mean, we routinely now can embolize these patients skin to skin in about 35 minutes. The recovery is about 35 to 45 minutes. It is a simple, elegant, minimally invasive, low risk procedure. Why does it need to be done in hospitals? Number one, that's sort of the logistical issue. Number two, like I said again, there is a moral imperative for PAD practitioners to learn this procedure. It is not rocket science. We do training courses all the time. I think we've done 25 or so in the last 2 years. We've trained so many physicians. I hear nothing but great feedback from the physicians saying, hey, we've helped our patients so much. So this truly is an outpatient procedure. And when you look at the big picture of declining reimbursements and things like that, and consolidation of hospital-led healthcare systems, this is an extraordinary way for independent practitioners to stay independent.
That's awesome. Well, and that kind of gets my next question. This is for both of you, but I think Amar, you might have a little more. You guys have done, I mean, hundreds of procedures. You have huge volume coming in the doors. I know we've worked with you and we see that you guys are seeing patients all the time. Coming into that, you have Dr. Rao's clinical experience, but how do you scale up the operations in a specialty OBL to really thrive? Because that can be a challenge.
Absolutely. And, just like anything else you learn, right? As with time. So it's a few things. It's people, processes, and knowledge. So you have to have good people that are ready to work, you know, that want to take care of patients, that care about what they do. Processes is obviously the number one thing to scale. How quickly can you get a patient in? How well can you take a patient and give them all their needs here? So we know every patient had to get an x-ray. So we got an x-ray machine. So that eliminated a step. So they come in and they have their entire workup, their x-ray, everything in one visit. How do you make it convenient for the patient? We were able to accomplish that. And then how quickly can you get a patient in for the procedure and prior auth? And so all of these steps that we have, we thought them through step by step, and we allowed ourselves to scale. Whether we have 10 patients or 100 patients a week, we can handle all of it in the same efficient manner. When Dr. Rao started his practice 5 years ago, he started with one principle that if a patient calls us before 4 p.m., they're guaranteed a visit the next business day. We have never strayed from that. So speed is also there, right? So we have the processes, we have the people, and then the third thing is the knowledge. And what do I really mean by that? So a lot of I'm a true believer, like you got to fix your backyard before you can do anything, right? Your backyard has to be on solid ground. So a lot of times, the MAs may not necessarily know what happens to the patients after the procedure, how it went on, or the nurses that were in the room may not see the patients in follow-up. So we make sure that we educate all of our staff, and we actually call patients in, and they come and they present to the staff, like, here's, this was limiting my quality of life before I had the procedure done. This was my experience. This is how I'm doing now. So what that has actually done, it's kind of interesting, is our staff is so vested in this because they see the results. You cannot deny the results. Our staff has brought in their family members. I brought in both of my parents. Our staff, it's kind of interesting, but one of my employees, he was at the gym working out, and he just, in the locker room, he overheard someone saying, this guy was an athlete, like a CEO, and he was saying, like, I love to go skiing, but I can't go because my knee hurts. And the second my employee heard that, he happened to have a pamphlet with him, and he turned around and he's like, hey, have you heard of GAE? You need to get this done. Gave him a pamphlet, and this guy, he researched it, looked it up, came in, got the procedure, and he actually did a testimonial for us, and he had just flown back from Switzerland skiing. So him and his friend go to a different place in the world once a year and go skiing. That's their thing. So, but my point is your staff have to know start to finish. They have to believe in it. They have to see the results. We have a registry, as Dr. Rao mentioned. We do research. We have all of our outcomes. We record all of our outcomes, and you can't deny data, right? Data is
King.
Exactly. So our staff, and it's interesting, our staff, even sometimes here, they'll see somebody limping, it's automatically like, is everything okay with your knee? So just because they believe in it so much.
I feel like we could do a whole podcast on this, but I feel like
absolutely, I'm so passionate about this. Yeah.
Well, and Dr. Rao, you can back this up, but I feel like a lot of providers, and I get to talk to a lot of IRs at OAIS and things like that, they're so caught up in doing the procedure well, which is their job, but they don't always think about what is the girl at the front desk saying, like how much work could really go into that. And I did a LinkedIn post that was a true story about a clinic I consulted where their front desk person was just okay. She wasn't excited to talk to people. She wasn't calling quickly. And we swapped her out with someone that was good and with training and scripting. And they saw like 20 more cases the next month with no different lead flow, nothing besides people wanted to come in and see her. And like that changed their entire practice.
Yeah, I give kudos to Amer for, helping sort of permeate my philosophy. From day one, I've always been take care of your patients, take care of your referring physicians. You got to be customer centric, right? You have to be customer centric. And that's why, like I said, North Carolina is the second most consolidated healthcare healthcare market in the nation. So North Carolina is the second most consolidated healthcare market in the nation. And we are still thriving in this incredibly difficult atmosphere because we've just put the only thing that matters at the forefront, which is the patient experience. Whether it's, like you said, it's a front desk check-in person, the medical assistant, the nurse who preps, the physician who takes care of the patient, or the business manager who has to talk to them about their bills and things like that. Everything is about the patient experience. I call it the Amazonification of patient care. It's smooth all the way, and customer service is the only thing that matters.
Well, I think something that gets missed, and we train our team a lot when we're doing, we've set appointments for you guys and stuff, is they are judging the doctor's level of care with how that first interaction goes. If that first interaction is empathetic and care good, they're going to assume the doctor is. It's a representation. And if that person's direct and short and hangs up on them, they're going to feel like the doctor's going to be that way. And that absolutely affects show rates. It affects rates to procedure and all the way down the line. And so you have to spend that time on those things.
100% agree.
So let's talk about the conference now that's coming up. So for physicians and clinicians who are looking to expand their practice, or maybe they want to learn about new procedures, why would the MMCC be an event that they should be at?
So, like I said, I think if you look at it from a patient-centric perspective, why should PAD practitioners know about this? So they can help their patients. So first of all, realize that your patients with PAD may also not be walking because of their knees. So come and learn about a disease process that has been so untreated or undertreated that you can gain this new knowledge, number one. And number two, like I said, we do training courses, and I'm happy to train physicians who have a good amount of peripheral arterial disease experience. You can come see what a multidisciplinary unit like ours does in terms of patient outcomes, take back some knowledge of the disease process, come back for a training course, and go help your patients. So you will be adding number one, a new service line in your independent private practice, number one. Number two, this is the most important thing. You will be helping patients beyond your initial imagination. It's unbelievable. My best success, Justin, I've been doing this for a long time. I've been out of fellowship for almost 15 years now. My best, my most stunning, my most repeatable success stories have been the EMBO patients. It's so heartening. The number of hugs we get, the number of tears of happiness we get from patients is just unbelievable. And if you're not doing a good job, they're not going to send their family members and friends, Justin. They all send their family members and friends to us. Anybody who's watching this, if you really want to learn to take better care of your patients, knee pain, leg pain, come to the conference, see what this new field is all about, and you will be doing an immeasurable amount of good in your community.
Absolutely. Well, and something you just said, and I hope for anyone watching this, especially if you're coming to learn to do the procedure, that's something you're interested in. The amount of clinics that we've come into that have had PAD for the last 10 years, and a simple campaign of us reaching out to those patients and saying, hey, how's your knee? Hey, let's come on, we have something new. That's turned into hundreds of cases. And now, like you said earlier, not only is that PAD patient's knee better, but their PAD is getting better. And it was from 2 days of learning something new. You've just changed your entire practice.
I couldn't have said it better.
And also with anything new, for physicians that come or anyone that wants to attend, it'll give them a good baseline. GAE is still in its infancy. A lot of people are now hearing about it. It's a buzzword. But like anything, it always takes a team and a collaboration of ideas and to take something and make it better. And we're just scratching the surface with the knees, right? Most people or the people I know have only done knees. No one's doing any other joints. Whereas with us, we're doing plantar fasciitis, ankle, hip, golfer's elbow, shoulder, hip, tennis elbow. So we're kind of in hand, of course. So I think it's just in its infancy, and this is the first of its kind, and this field is only going to grow. And the only way it can grow is with sharing of ideas, collaboration from all specialties, all different types of physicians that take care of these patients. So it is definitely something very different and unique and first of its kind. And we wanted to design it that way. We wanted it to be something different, not just another conference, but where people actually come and get something out of it. So we actually also have patients that are going to be coming to the conference as well and sharing their stories and stuff. So we truly tried to think of
including some local area physicians who got treated by us.
That's right.
That's the best. Well, and I want to say this again. I'm always thinking about who's watching this because we talked a lot about PAD, we talked about GAE, but like for us, we scheduled 1,500 procedures last month across our clinic. So we got to see a lot. And the data is really interesting because as this field develops, like PFE, much younger population, much quicker to take action on things. You have these other things that are coming out that you're going into a whole different patient population if you want that. And also to the provider, if you work with sports medicine, if you're doing these things, those plantar fascia patients, you could help them so much more than anything else. And so it's not pigeonholed anymore into these older Medicare populations. It's across the board.
Agreed. Yeah. Chronic musculoskeletal pain does not differentiate between age, gender, race, socioeconomic status, nothing.
So I know you guys are talking about a lot about hands. What's the next thing that you're really excited about? Or where are you seeing the research going?
Spine. I think chronic low back pain is such a disabling illness that I think that's next. Well, that needs to be addressed, that needs to be researched, and that's one service line we hope to add pretty soon in the next few months.
Well, I'm sure because again, I do a lot of post-op patient interviews, and what does every patient say when you get done? It's like, can you do my back? Right? I'm sure you hear it all the time.
Yeah, that's exactly right. I think that is the final frontier for me.
Well, Dr. Rao and Amar, I really appreciate you guys coming in. Can you have any closing messages on how they can find out more about MMCC?
Absolutely. So if you go to raoclinic.org, that's RAO clinic.org. All of the information is on there, the agenda, details about where to stay. I think it's something that people really benefit from. It's the first of its kind, and we invite everyone to come and share ideas and thoughts and experiences so that we can make this better and help all those in need for with this disease.
Justin, just to add one more thing, it is 7 hours of CME, so it is a CME accredited meeting.
Well, and guys, for those of you watching, you also get to see me. I'm going to be out there presenting with them in Raleigh as well. But guys, check out the event, Raleigh, North Carolina, October 4th, 2025. And guys, thank you so much for being on, and I look forward to seeing you guys there.
Absolutely. Thank you very much, Justin. Thank you.